All right. All right. Good afternoon, everybody. Is my mic working? All right. All right. Good afternoon, everyone. Thanks for coming in for this Mackinac Center Issues and Ideas Forum. I'm Jarrett Scorup. I'm Vice President for Marketing and Communications at the Mackinac Center. For those who don't know us, we're a free market economic think tank. Our headquarters is in Midland, and then we also have this nice office here in downtown Lansing that we share with some other groups. So the issues and idea forums that we try to do are on active policy issues, things that lawmakers might consider. And a lot of times it's tough because we're planning these a couple of months out. And this one ended up working out really well. Not necessarily for good reasons, but a lot of these are issues that are ongoing at the state and federal level. So we have a great panel here today, which I'll introduce in a second. So this event is Health Policy Changes in Michigan's Recommendations and Warnings. Healthcare is one of the fastest growing expenses for consumers as well as taxpayers. Public health spending is now the largest part of the state of Michigan's budget. And what do we get for all that money? Are health outcomes improving as a result of more government spending? A lot of research suggests that it is not. While the United States has some of the best medical facilities, technology, and treatments, we spend significantly more than other nations for it. And on top of that, government policies are restricting the supply of healthcare while also heavily subsidizing it at the other end. So what can state lawmakers do about it? We'll discuss a variety of health policy topics Michigan should adopt, including things on hospital monopoly laws, scope of practice rules for healthcare workers, and improving regulations related to drug pricing. So today, I'm very happy to be joined by Dr. William Smith. Dr. Smith is a senior fellow, director of the Pioneer Life Sciences Initiative. He has 25 years of experience in government and in corporate roles, and his career includes senior staff positions for the Republican House leadership on Capitol Hill and the White House Office of National Drug Control and the Massachusetts Governor's Office. We also have Josh Archambault. He is a visiting healthcare fellow at the Mackinac Center for Public Policy. He's the president and founder of President's Lane Consulting with a wide range of senior legislative aid experience, working for a variety of think tanks, and he's a regular contributor to Forbes.com. He has a master's degree in public policy from Harvard and a BA in political studies and economics from Gordon College in Massachusetts. And then on the Zoom, we have Matt Mitchell. Matt is a senior research fellow and certificate of need research coordinator at the Niche Center for the Study of Occupational Regulation at West Virginia University. He's also a senior fellow at the Center for Economic Freedom at the Fraser Institute and a senior scholar at the Mercatus Center in Washington, D.C. He's been featured in most every news source that you can probably think of, including the Wall Street Journal, Washington Post, National Public Radio, and C-SPAN. And we are hoping to match the C-SPAN audience today. So Matt really has a lot to look forward to. All right, the way it'll work, we'll give kind of some short topics about what these gentlemen are going to talk about. And then I'll do a couple of moderated questions, and then we'll take questions from the audience. So you've got cards in front of you. You can write down questions there. We'll pass them to the end and then kind of sort through those and do some questions. And then if you have more than that, we'll be hanging around afterwards if you want to come talk to us. So first, Josh, let's start with you for your opening talk.
Sure. Well, I'm really happy to be here today. And what I'm going to do in my opening comments is just talk a little bit about, at a high level, what are two buckets of areas in which states, as they came out of COVID-19, should really be making sure that they have a laser focus. And for those of us that remember going back to 2020, if you worked in the legislature or around it, so many questions about what do we do, how do we move forward. And the good thing for those of us that have been in kind of free market healthcare policy is we thought, do all of the things that we've been saying for years to do that would make for a more flexible healthcare system. And I think COVID really put the health system in a big strain and pointed out a lot of the problems that are there that don't make it a flexible system, don't make it patient friendly, don't allow providers to see patients in different ways. So the two buckets I want to briefly talk about, and I'm happy to in Q&A go into much greater detail here, is just and there's a bucket of reforms that states can do that have to do with how do patients interact with a provider. Who can they see? When can they see? What can they see them for? What kinds of facilities can they see them? Matt's going to talk about some of those, so I won't go into all of the detail. I'll come back to this in a minute. The area where states probably still have the most work to do is in telehealth. A lot of states have passed telehealth reform laws. I would say we do a 50-state analysis every year. I'd say most states are still tweaking around the edges. Unfortunately, they've been sold a little bit of a bill of goods by special interest groups who say, fix the problem for my group. Don't fix it. They're not saying don't fix it for the whole system, but they're really just focused on whatever their trade association is focused on. So I'll talk about that for a second. But the other one that I wanted to talk about is reforms around how we pay for healthcare. There hasn't been a lot of innovation, especially since the ACA or Obamacare passed. And there's been just a lot of frustration. If you're a small business owner or talk to small business owners, individuals who don't go to subsidy, it is crushing the cost of health insurance. And the survey data on patients putting off care is growing increasingly bad by each year. And so we have these big questions about, do we need to try different ways of paying for care? And we'll talk briefly about those. So let's start with that first bucket of how do patients interact. On telehealth in particular, raise your hand. How many people have done a telehealth visit at this point? Almost everybody. All right, so before COVID, that was, maybe 3 or 4 of you would have raised your hand. Now most of us have had that experience or have had family members do it. It's not a silver bullet, shouldn't replace all in-person visits, but it's a tool in the toolbox. But there's some really important things that need to be happening. The one I want to highlight most is across state line telehealth. So we allow pilots to cross the state line and assume that they don't lose all of their ability to then take off when they need to again. But effectively, that's what we're doing to medical professionals with telehealth. We're saying we just assume you are unable to see patients in our state because you, as soon as you cross the state line electronically, have lost all of your knowledge. I think that's just short-sighted. We are an increasingly mobile society. People live in Michigan, then they decide to go down to Arizona or Florida or somewhere else for certain parts of the year. And it's far better for them to stay in touch with their providers than it is for them to break the law if they want to stay in touch or just not tell you where they are when they're doing the visit. So there's been a number of states that have passed laws that just make it very clear that if you're in good standing and you're a provider in another state, that you can either register in Michigan or you could some states don't even require a registration. You can start to see patients. And I think this is just a game changer in rural communities for certain kinds of services like mental health services, for team-based care. I think what's happened is that a lot of states have gone down this compact route, which is an agreement saying that if you're a certain kind of provider, you can do a cross-state line. But there's problems with that. The compacts only apply to one kind of provider. They only apply to the states that have passed the compact. They're slow, they're expensive to be able to get through that compact process. It's better than nothing. But the reality is that we're facing is that for many patients, the difference between having access is seeing a provider over telehealth or seeing no provider at all. That's really the reality in which we're facing in many communities in Michigan and other states. And so I do think states need to take a very hard look at this, really make sure that every kind of provider can use telehealth. Don't mandate it, but just say it is an option. It's a tool in your toolbox that you can do it across state lines, and that we're going to allow you to use any device that you decide for the patient. And for those that are still dealing with the opioid crisis, fentanyl crisis, if somebody is willing to get clean at 2 o'clock, 3 o'clock in the morning, and they want to start by text for telehealth asynchronously, we should allow them to do that. Their local offices aren't going to be open. It's only the ER that's going to be open at that point, and that is not the best place for them to enter the healthcare system to get the help that they need. So we want to make sure that our telehealth laws in particular are really flexible. So that's kind of the first bucket. The second bucket that I want to just briefly mention is looking at how we pay. So the one that's related to COVID in particular that has been a little bit concerning looking what's happening here in Michigan is related to redetermination of people who are on Medicaid. So during COVID, Congress passed a law that basically said we're going to give you a little bit of extra money if you agree to not remove people off Medicaid. And again, Medicaid is for lower income, traditionally has been for lower income individuals. Well, as we kind of came out of COVID, there was some pressure, and finally, millions of people were added to the Medicaid program. States were having to pay for more and more of it, and so there was some pressure. Congress eventually removed those handcuffs, if you will, and said you can start redeterminations. Well, unfortunately, here in Michigan, things were delayed. They're taking quite a while to get there. And I think there's some questions about the integrity of the eligibility checks that they're doing. Are they being as robust as they can be? And let me be clear. This is for people who are no longer eligible for the program. If you're still eligible for Medicaid, you'll stay on the program. It's for those that are no longer eligible. A lot of these people maybe got laid off during COVID. They went on Medicaid. They were never removed. They got hired somewhere else. They got employer-based insurance. And we've been paying twice for them. Both the employer has been paying for them and the states have been paying for them. And in a state that uses managed care, which Michigan is, you're paying an insurance company a monthly fee every single month. And that individual is not using any services. So we're literally just padding the bottom line of managed care companies. And so this is taking money away from public education, lowering taxes, whatever other public priority you want to do. So that is an area that needs a lot of focus on how we're paying for those services. The other things I just wanted to mention briefly is there's a lot of work to be done on price transparency at the state level. Some of you have probably are aware of some of the regulations that were passed under the Trump administration and the Biden administration has kept at the federal level, but there is even more that states can do. This is how we pay for healthcare. If you have a deductible, patients have to pay for it. And so you want to make sure that they know how much things cost. But there's a lot of activity at the state level. Tennessee and Texas this past year passed a law which says that if you go out and you pay cash for something, and it's less expensive, then your insurance company has to recognize that toward your deductible. We're trying to create an actual market in healthcare. These are the sorts of things that states can kind of move forward and help individuals as they're trying to pay for healthcare. And then the final bucket I'll just mention is there are some states, about 8 or 9 states, who have passed something called Farm Bureau plans. It allows farm bureaus or entities like them to offer something that it's not insurance, but looks like coverage, health coverage. People do have to undergo underwriting, but then they can keep the plan for life as long as they pay their premiums. If they switch jobs, they don't lose their insurance. It's guaranteed renewable. There's some huge benefits that we don't have in our employer-based system that I think states can lead on, offering these new opportunities for small businesses and others. And you don't even have to be a farmer. You just have to be a member, support agriculture in that state. So I think most people can be supportive of that general mission. And I think in Tennessee, it's $35 a year to be a member of the Tennessee Farm Bureau. It really is a great opportunity. Those plans tend to cost about 50 to 70% less than the ACA plans that are out there. So really a significant difference for them. And the final one I would just say where states need to pay a lot of attention, not directly related to COVID, but has a big impact on the market, is for public employee health. I think a lot of states have not done a good job of being good stewards of how they pay for health insurance for whether it's teachers or others. There's some innovations paying savings incentives when public employees shop around for care. Not everybody's going to shop, but it allows you to reward patients in a pretty meaningful way for public employees to get money and actually save dollars that they can, whether it's pay raises or other opportunities or tax cuts that you want to fund. There's good opportunities there. So those two buckets of how patients interact with the system and how you actually pay for it. Huge laundry list, a menu of where states can lead on those. So.
Why don't you tell us about some of these other large issues being taken up at the state and federal level?
Thanks for inviting me, Jared. I was asked to talk about price controls, which there's a lot of activity on price controls at both the state and federal level. Before I get into the details of the federal and state proposals or laws, let me just make some general remarks about price controls. We have some major experience with government price controls in a lot of sectors besides prescription drugs. And the government tends not to do this well. And the government can make mistakes on price controls in 2 different directions. One, they can set prices too high. And what happens when you set prices too high is you get oversupply. And some of you may remember, if you're old enough, the 1970s when the government had all this cheese. Because of dairy price supports, they kept the price too high, and millions of pounds of cheese were stored in caves all across the Midwest because the government set the price too high. The government can also set the price too low, and what happens when the government sets the price too low is you get shortages and scarcity. My son just moved to New York to go to business school and had to find an apartment, and almost half the apartments in New York are rent controlled. It's very hard to find an apartment. Nobody wants to build new residential housing because of price controls. So you have shortages. The other thing that happens when the government sets the price too low is you get underinvestment. So we have some experience with this in the electric utility industry. Those prices are set. There aren't shortages of electricity because the utility boards would be on the hot seat if they did have shortages. But there is significant underinvestment. I want to show you a picture. The Zoom people may not be able to see this, but this is a parade that's happening in Binghamton, New York in 1905. And you'll notice that the electric wires are very similar to the ones we have now. There just hasn't been significant investment in more efficient ways to deliver energy. I mean, it just doesn't happen. And getting rid of those wires, you'd think would be a priority of the industry. They're unsightly, they're inefficient, they fall down. Hasn't happened because price controls in the utility industry prevents investment in new technologies. So in general, if you wanted to really see shortages in Michigan, make gasoline $1.50 a gallon. And what would happen immediately? Gasoline wholesalers wouldn't deliver to Michigan gas stations, and you'd have a widespread shortage. The same would be true with food. If you price controlled corn, farmers would plant soybeans, and you'd run out of cornflakes. This is one of those ironclad laws of economics where price controls simply don't work. When you push prices too artificially low, you get shortages. And when it comes to prescription drugs, what you're going to get is shortages of new drugs. There's just no doubt about it. Now, the government, through the Inflation Reduction Act, has passed price controls in the Medicare program. And on October 1st, they released a list of 10 drugs that they're going to price control. And then next year, they'll release a list of 15 more, and then the year after 15 more, and then the year after 20 more, and 20 more, and 20 more. So you're going to have most of the drugs in the Medicare program are going to be subject to price controls. And economists across the board agree this is going to create shortages of new drugs. There's some disagreement about how many new drugs are going to be affected, but the CBO said 13 to 15. Some economists have said more than 100. There's no doubt there's going to be shortages of new drugs. And there are a couple of therapeutic areas, I think, where you're going to see real shortages. Cancer and neurology are two therapeutic areas that are going to be most hard hit by the Inflation Reduction Act. And that's because on so-called small molecule drugs, and small molecule drugs are the kind of drugs you get at the pharmacy. The little pills that come in a bottle, yellow bottle, those are generally called small molecule drugs because they're less complex compounds. Large molecule drugs or biologics are the kind you'd get infused or injected maybe in a physician's office or a clinic. But what the Inflation Reduction Act did is they allowed price controls to happen 4 years quicker for small molecule drugs than large molecule drugs. You can slap price controls on a small molecule drug 9 years after it's been approved by the FDA. You have to wait 13 years for large molecule drugs. What that's going to do is drive up cancer and neurology research. And that's because there's something in the body called the blood-brain barrier. Small molecule drugs can cross that barrier more easily than a larger molecule. And that's, the blood-brain barrier is just a natural part of your body to prevent foreign substances from getting into the nervous system. So, but so a lot of cancer drugs and neurology drugs have to be small molecule drugs. And the research on these is going to dry up. There was testimony in front of the Energy and Commerce Committee last week where a biotech executive had surveyed the 100 top venture capital firms that gave financing to biotech companies. And out of the 100 firms, 85 indicated that they were backing away from small molecule research projects. That's a nuclear winter, actually, for oncology and neurology research. So this law, in my view, is going to be very, very damaging. When it fully kicks in, it's going to take $80 billion a year out of the biopharma sector, and that the number of research projects is going to be diminished significantly. There's just no doubt in my mind about that. Michigan has a proposal, which I think may have passed the Senate, to have a price control board, just pick a bunch of citizens to figure out what the upper limit prices should be on prescription drugs. again, this is, I don't know why they would be doing this, given the problems with price controls. And moreover, now that the feds are going to price control virtually every Medicare drug, and they're going to publicly announce what the price is for each drug, the new price, under the price fixing measure. I don't know why Michigan just doesn't piggyback on that. For those who support price controls, why not just choose the Medicare price? It's going to be very low, and they're going to have economists and other experts in the federal government deciding it. Why create a new bureaucracy in Michigan to set drug prices when the feds are going to do it? Not that I support what the feds are doing, but it seems to me wildly duplicative and redundant. So let me just close there. I could go into some of the details and complaints I have about the Michigan bill and about the IRA, but maybe I could go into those during questions.
All right. Our third panelist will go to Matt Mitchell and talking about certificate of need. Yes.
Industries, but most commonly in healthcare. So here's a general overview of what I want to say. So we give you a brief idea of exactly what these laws are, a typical history lesson on where they came from and why they affect patients and access to care, and then the heart of what I'm going to discuss is this very rare literature on certificate of needs. So briefly, what is a certificate of needs? So the best way to think about it is it's really a permission slip to. So these are laws that are found in about 35 states. It depends on how you measure them. Whether you're looking at a sort of a comprehensive program or a non-comprehensive program. But they're found in these states, and they require anybody who wants to open or expand a care facility to first prove to some sort of regulator that the service in question is needed. So this is a rather unusual type of regulation, insofar as in 99.9% of markets, anybody who believes that they want to offer a service must obviously think that the service is needed, because they think the real test that we need is whether they think it's a viable service profitability. But in healthcare, it's essentially second guessing the provider's assertion that the community could benefit might need the service. So one thing that's important, especially since we're talking about healthcare, I think a lot of folks, when they hear about any type of healthcare regulation, sort of assume that, okay, there's got to be some kind of patient, protection that's involved here. They must, when you try to meet the need, surely the regulators are asking questions about your qualifications. Surely they're asking questions about the adequacy of your facility, maybe your safety record, things like that. In the case of certificate of need, they are not asking those types of questions. Again, they are simply second guessing your assertion that the community needs the service budget. Now, this is one problem with this, of course, is that need is subjective. So you may say that you need a knee replacement. Well, really, you don't need it to be right next to you. It's fine for you to get into a car and drive all the way across the state in order to get your knee replaced, right? So you may say that you need, to give an example that's prominent, you say that you might need somebody to offer home health care to you in a way that is recognizes your unique culture. So, for example, in Kentucky, there was a pair of Nepalese immigrants who wanted to offer home health care to the large Nepalese population in Kentucky. And one of the things that they offered was language and culture specific care. Well, according to the state of Kentucky, patients there don't need that care. All they need is to have supplemental. So again, need is subjective, and it's very difficult for providers to, for a regulator to really do second guess or to get into the head of what a consumer actually wants, which is one reason why in 99.9% of other markets, we don't put the regulator between the provider and the consumer. We just allow the provider and consumer to figure out what's needed. Okay, so that's kind of the idea of they tend to, in order to prove need, often there are fees involved. These fees range anything from, it can be a set fee up to a percentage of the capital investment that you're hoping to undertake. But the fees are probably minor in comparison to the compliance costs. So it typically takes a provider months to prepare these types of applications. Sometimes it can take years as you go back and forth and negotiate with the regulator on whether or not the community service. In that time, applicants can spend tens, sometimes even hundreds of thousands of dollars trying to prove the community could use the service. So here's a look at some of the services and technologies that are regulated in Michigan that require a certificate of need law. If you want to offer neonatal intensive care, you've got to prove that community needs it. If you want to offer psychiatric services, you have to prove that the community needs it. If you want to offer organ transplants or nursing home beds or hospital beds, you have to prove that the community needs it before you start offering it. So where do these things come from? So the first state to adopt a certificate of need law was New York in 1964, but it really got a big boost in 1974 with the National Health Planning and Resources Development Act. So this was a bill that was sort of at the heyday of central planning and the idea that we could, perhaps constrain costs if we have everybody on the same plan. The federal government decided that they wanted states to adopt these regulations, and so they threatened to withhold federal funding from any state that did not adopt a common law. And President Ford ended up signing it in 1975. Really, within a decade, there were already a number of studies suggesting that these rules don't work. If you know anything about economics, you know that the idea of restricting supply, you're typically not going to increase supply. And yet that is exactly what the law was intended to do, was to increase care for, especially for, certain populations, rural populations, vulnerable populations. And so already they had evidence that, okay, that wasn't working. Another goal of the regulation was to decrease costs. Again, if you know anything about economics, and think about a shift left in supply, that's really not going to decrease costs. It's most likely to increase costs, and sure enough, they already had evidence of that. So a bipartisan initiative was launched to get rid of the federal mandate. It's a Democratic Republican President Reagan signed the repeal of that portion of the National Health Planning and Resources Development Act. Just to give you a sense of sort of the climate there, there's a representative, Lord Boland from Central Georgia, who's a physician. He really ran for Congress on this issue. He actually wanted to go further. He wanted Congress to outlaw state certificate of need laws. He didn't get what he wanted, but it gives you a sense of the idea that there was a time when it was really pretty recognized across that ideological spectrum that these rules just is maybe a nice experiment, but it just wasn't working. So the interesting thing is, as a result of this experiment, we have quite a bit of variation across the states in terms of which states have certificate of need laws and how extensive these laws are. And the other interesting thing about it is it's an evolving landscape even today. So in 2022, this is what the map looked like. By 2024, it's going to look like this, and that's because Montana did away with most of its certificate of need laws last year. And South Carolina is in the process of doing away with most of its certificate of need laws, as well as there have been more modest reforms in North Carolina and West Virginia. So perhaps you've walked by an economist's car and you've seen this nerdy bumper sticker, "I love federalism in the national experiments." Perhaps you're a legal scholar and you're familiar with Justice Brandeis's famous observation that it's a happy coincidence in federalism that states can pursue experiments in policy as a laboratory of sorts. What you may not remember, or at least I didn't, So I looked it up, was that famous Brandeis case, dissent, was actually a certificate of need case. It had to do with an odd area, was it had to do with ice, in selling ice. He's in Oklahoma, and Brandeis wanted their states to be able to, continue to have the ability to experiment with policy. So the interesting thing is, because so many states have repealed common laws at different times and in different ways, we have this surfeit of data. And so it's been an extraordinarily well-studied phenomenon. In fact, I will say this, I know of no other area of public policy that has been subject to so much study, especially if you account for the fact that it is so widely unknown. So this is an issue that we know quite a bit about how it works, even though the public doesn't, it's not really on the public's radar and it doesn't get a lot of attention. So there have been 128 peer-reviewed studies. I'm focusing only on academic studies or government commission studies that have been performed by academics, many of which actually end up going on and getting put on academic publication. So 128 peer-reviewed studies. Now, most studies actually ask more than one question. They might look at how con affects access as well as cost, or quality as well as access. And so together, these 128 studies actually contain 423 separate tests assessing the effect of con on things that we may care about. What's sort of a quick summary of this literature? Well, basically is in 4 different categories. Most of the tests are focused on access, but quite a few are focused on spending, both quality and underserved population. So let me briefly give you an overview of this. So there have been a total of 103 tests assessing the effect of on spending or efficiency, somehow defined. The majority of these, in fact, 5 times as many tests, find that their con is associated with increased spending, increased cost, lower efficiency, than find that it's associated with higher efficiency or less spending or costs. You might be wondering, how could it actually ever find that it's associated with greater efficiency? One of the main ways that, one of the main types of categories of tests that find that are ones that do find that, okay, by limiting the number of providers, maybe more services will be channeled through providers, and so the providers might use their equipment more efficiently. Ironically, actually, I'm a bit of a con skeptic, but I contributed to that portion of literature. So I did a study with Stratman at George Mason University, in which we found that during COVID, states that regulate the acquisition of hospital beds were about, hospitals there were about 33% more likely to run out of beds during COVID. Others have found that patients actually that use those were more likely, tragically more likely to die. So even though my study was focused on access, I actually gave a little bit of fodder to the advocates of con, because we did find that yes, they were more likely to run out of beds, but that doesn't mean that each bed is used more efficiently. My reaction is that's not really a very helpful or useful metric. What we really care about is how much we're spending per service. And on that score, the data is really very clear. On-log work exactly how economics would predict. If you restrict supply, sure enough, you spend more. As I mentioned, the largest area of research is on access. There have been 171 separate tests assessing this question. Again, there are 5 times as many tests that find that con reduces access as find that it increases access. What we find is that in states like Michigan and con laws, patients have access to 30% fewer hospitals, 14% fewer ambulatory surgery centers. They have rural patients in these states have access to 30% fewer rural hospitals and 13% fewer rural ambulatory surgery centers. They have access to fewer hospice care facilities, fewer dialysis clinics, fewer cancer treating facilities, fewer hospitals offering with MRI, CT, and PET scans. They have access to fewer substance abuse facilities and psychiatric care facilities. We find that patients have to drive longer distances in order to obtain care in con states relative to non-con states, and they're more likely to leave their state in search of care. So it's really quite clear, Con throttles access, which is, again, no supply of human surprise since it's a nutrition on supply. And then finally, actually, second to last is quality. Con laws, again, they don't actually tend to assess quality. So any effect on quality is sort of a byproduct. The advocates of Con sometimes say that it might increase quality by channeling more services through providers, and some other providers might get better at offering services. It's okay theory, the data for it. In fact, what we find is, again, there's quite a few, many times more studies find that underlying quality has enhances quality. So what are we talking about here? Well, patients in Con states are much more likely to, or statistically significantly more likely to develop post-surgery problems. They're more likely to have lower survival rates following heart attack and heart failure. They are less likely to give their hospitals an 8 or a 9 or a 10 on the 10-point scale. Nursing home patients are more likely to be physically restrained in Con states relative to non-Con states. So the basic idea here is that if you limit competition, we find in market after market, competition tends to enhance quality, and that's true in healthcare as well. The final area that I want to talk about is underserved populations, especially because this is a common rationale for laws. This is one where there's actually zero evidence that Con increases access for underserved populations. There among 13 tests, 3 find mixed results, but the other 10 associate Con with diminished care for underserved populations. We're talking fewer rural providers, lower profitability for safety net hospitals in Con states. One study found that a large black-white disparity in provision of care disappeared in New Jersey after they repealed the Con for that specific type of procedure. So, there's just really no evidence that it protects underserved populations. Not only does it restrict care for the general population, but it seems to restrict care for underserved populations as well. Just kind of lump everything all together. More than half of the studies find that Con is associated with some sort of bad result. Just 11% of the studies find Con being associated with any sort of good result. One of the things I try to emphasize to policymakers, around the country is, you're going to be told by hospital associations that if we get rid of this, all hell will break loose. Your patients won't be able to get care. Hospitals will close. But you don't have to wonder what will happen, because about a third of the population actually happens to live in one of these states with zero or very limited state regulation. We can look at what's happening to the patients in those states, look at that real world experience. We find that in states that don't have the community laws, they spend less, and greater access to care, and quality care, even for underserved populations. So that's all I have. Happy to take questions and look forward to the conversation.
All right, thank you, Matt. So we're going to move in. I'll have a couple of questions, and then if you think of some, write them down. We'll start passing them down to the end, and then we'll start taking questions from the audience. So the first thought on this that comes to mind, and the question I have is how these laws come to be. So Josh, you talked about these restrictions on people moving into the state and be able to work, these restrictions on things like scope of practice, these required extra licenses, prevention of telehealth. And then Matt, you kind of got to it a little bit at the end of there, but these certificate of needs, it seems so obvious. I mean, if we want to open a grocery store, food's pretty important. If you want to open a grocery store, you go open a grocery store. But if you want to open a hospital, you want to expand hospital beds, even a licensed and certified hospital that already exists, you have to go to the state board in Lansing to get permission to do it. So how do these laws come into being?
Well, I can start and then Matt can jump in. I mean, I think there's probably 2 ways that it comes about. One is somebody is clearly trying to put a barrier up and has been for years. So they view competition as a bad thing. And so they come in and make these arguments, some that Matt just tried to, pointed to, oh, well, these out-of-state doctors are going to experiment on, I'll tell you a real example in Idaho, a testimony of a dentist who said these out-of-state unlicensed dentists, which wasn't even possible under the reform, are going to experiment in their garage on Idaho patients. Those are sorts of arguments you hear, which don't even they're not even logical because we're talking about telehealth. So how are they going to be in there? Anyways, those are sorts of arguments that get made. And so it's an active effort to try to put up barriers. More often than not, though, something just in telehealth in particular, the laws have just never been updated. They haven't kept up with technology. They haven't kept up with societal change, people being more mobile and, being snowbirds or other dynamics that we just need to be aware of. And so because the government is so involved in the regulation of healthcare, if you're going to continue to have them be involved, you have to constantly be updating their rules and regulations to make sure that you're at least not making it worse in terms of it. And then we may bleed into these broader conversations of I touched on it, Bill touched on it. How you pay for something drives a lot of how the system ends up looking. And so the way Medicare pays for whether it's drugs or other things, unfortunately, the market, I can tell you in VCs I've talked to, how many entrepreneurs are coming to VCs and building their models based on Medicare reimbursement for a product that's not even for seniors. But that's how they think through, well, if I can get Medicare reimbursement, then I will have this huge market of potential patients, or I know the private insurance will follow what Medicare is doing. And so, unfortunately, I think that has driven a lot of the dysfunction in our healthcare system, where it is not this true free market in any sense of the imagination of most of the healthcare world because of how we pay for it. And as a result, that's why we get what we get.
Go ahead, Matt. How did these come into being and how did they end up staying?
So there's an economist named Bruce Handel who has a nice metaphor for this, and I do think it's apt. He calls it the bootlegger and Baptist model of regulation. And the basic idea here is he takes it from looking at flu laws, in certain parts of the country where you aren't allowed to sell alcohol on Sundays. And these laws are typically supported by a strange bedfellows type of coalition. On one hand, there are religious groups, they also don't Baptist, but people who don't want the sale of alcohol on Sundays for essentially a publicly spirited reason. They have a good rationale. They want to try to help protect the public. But ironically, you also then have other groups like bootleggers that are also happy to have this regulation because they are quite happy to not have to compete with legitimate sellers of alcohol every week, right? And so you can find bootlegger and Baptist coalitions all across the regulatory spectrum. And I think that's really what's going on here. So, we're on the Baptist side, there are quite a lot of true believers who just think that if we somehow could rationalize the provision of care and make everybody get on the same plan, then we might be able to restrict the supply of unneeded services. Maybe this is a stronger argument in certain areas of care than in others. It's really hard to understand how even that argument could possibly apply in some cases specific need, for psychiatric services or substance abuse services or neonatal intensive care units. I don't think Michigan regulates burn care, but many states require comp for burn care. Those are types of care where it's unheard of and sort of ridiculous to imagine that anybody would care, right? It also doesn't really make sense in lower cost version modes of care like hospice care, which we know actually are a much cheaper way for end-of-life care than hospitals. So you've got this kind of Baptist rationale that maybe this will help, but really the truth is, I think a big driver is the bootleggers. And in this case, the bootleggers are hospital associations. Hospitals, especially large hospitals that find that, that have large compliance departments, are able to comply with these laws. These laws limit their competition from smaller providers, and they manage to keep them on the books. It probably helps that the rule is sort of technical. Most people don't know about it. It sort of sounds confusing. It vaguely sounds like it might have something to do with safety. You kind of add in all of that, and you've got a recipe for keeping the law. Another sort of metaphor that's I think quite descriptive is just the idea of concentrated benefits at huge costs. The benefits of this are there and are benefits. Hospitals in the short run gain some higher profitability as a result of these laws. But those benefits come at the cost of payers, insurance payers and taxpayers, as well as patients, right? And so those who bear most of the costs, especially patients, typically don't even know that these laws exist, and if they do, they're not really politically organized to stop them. So as a result, they exist.
Yeah, and of course, I think there's something a lot of people, and for a lot of lawmakers, present company excluded, of course, that where you have the thing that you see right now, and it's hard to kind of envision these future health facilities and services that might be available. I'll ask one more question. Go ahead, pass your questions down to Holly there at the end, and she'll hand them up to me. So, Bill, this is a little bit into that kind of, I guess, monopoly point we're making. I mean, there's legitimate complaints, right, about that we need these drugs. The costs are increasing. How do we help people afford them? So I guess it's a two-part. One, and Josh, you can jump in as well. Like, what's driving the higher prices? And what's driving it in general? And then just how would lawmakers get at that point of trying to get a little bit more competition in that market?
Yeah, what's happening in the biopharma R&D world is that thanks to the human genome and other advancements, we're learning more and more about subpopulations of patients. So they used to treat lung cancer the same way. You're diagnosed with lung cancer, you're going to get chemo and radiation, and that's it. Now they've figured out through the human genome that there are 7 different types of lung cancer, and some of them are quite rare, maybe only have 5,000 patients in them, and they're going to be treated differently. But if you're going to do the R&D and come up with a drug for 5,000 patients, only 5,000 customers in the whole country, that drug's going to be expensive. That's just the reality. Now, that said, average drug prices have been dropping for the past 6 years. The data is very clear on that. Thanks to rebates, discounts, and other price concessions, drug prices have been dropping. And they're dropping largely because big blockbuster drugs are going generic. That's what happens. When the patent expires, a generic company can copy it. Lipitor, which was a famous drug of Pfizer when I was there, I used to bump into a guy from Michigan Blue Cross, and he'd complain to me, hey, we're paying $4 a pill. I got millions of people on this drug. I said, well, wait till it goes generic. And a year later, I saw him at a conference after it went generic. And I said, what are you paying for Lipitor now? He said, 4 cents. So that's how dramatic the price drops are when drugs go generic. And so those generic drugs coming into the market are offsetting these more expensive drugs for rarer diseases. So average net drug prices are actually dropping. What's happening, though, is the reason this issue resonates with people, despite the fact that drug prices are dropping, is that there are some people who find themselves on a rare disease drug that have very high out-of-pocket obligations, a high deductible health plan or other co-insurance requirements, and they suddenly get cancer and they're on a $50,000 drug, and they have $10,000 they've got to pay out of pocket. Now, that's a genuine problem. I think that's a problem that can be fixed because it only affects a single-digit amount of the population. But that's what's driving this issue. It's not skyrocketing drug prices. It's the combination of rare disease drugs coming out that are quite expensive, and then people having an insurance benefit design that requires them to pay a lot of out of pocket.
All right, we'll move on to the questions. We got a lot of really good ones. We'll see what we can get through. First question is on kind of this third-party payer system we have set up, which is different than a lot of other areas of the market where a lot of times people don't even know what the cost is or what they're going to pay. And especially, they note that on certificate of need, the idea was to restrain prices like Matt noted. But, you're relying on someone where it's a third-party insurance paying for something to someone who might have a financial interest. So how do we get at that issue of overutilization, people using too many services outside of having a con law or something else? And note that we have not said con is a con yet during this panel, which is a first for anyone who's ever talked about this. So
there's a lot in that question. So let me just try to tackle
2.5 hours.
Yeah, that's right. Let me just tackle the like employer-based one. That's a federal law change that will probably not change anytime soon. If for those of you that remember, John McCain had put out a plan that was going to tweak the way that we did employer-based insurance, and the Obama campaign, till to this day, is still the single most like run presidential political ad was against that plan. They saw in the polling that it was incredibly unpopular. So I don't think that's going to change anytime soon. Obviously, we've got one political party who has kind of put a line in the sand saying we want single payer. So we'll continue to have this conversation of who gets to stay on employer-based insurance versus who's going to be put on Medicare. So that debate's not going away, but I don't think it's going to be resolved anytime soon. The question is more about incentives, I think, here, which is how do we make sure that we align incentives for patients? And unfortunately, given the politics, both at the state and the federal level, I don't think there's easy answers to this, but there are, and I hit on a number of them. There's a bunch of tools that we have available that can help patients and providers better navigate the system. So whether it's paying differently through a Farm Bureau plan, allowing small businesses to self-insure, making them look like and act like large businesses, association health plans kind of get at this same dynamic. You can align incentives to invest in preventative care and keep an individual with you for decades instead of what we have now, which is people are switching jobs every 4 to 5 years and therefore switching plans. And there's really no incentive for the insurers to invest in your long-term health because you're not going to be a client of theirs. Some of you may be familiar with direct primary care arrangements. In Michigan, you call them retainer agreements here, something slightly different. This is where you pay a monthly fee to a certain kind of provider. The most familiar is for primary care. I think we're going to see a lot more of these sorts of products coming onto the market or opportunities where it's almost an alternative to the status quo, big, large systems for people to be able to do. So you'll see employers going through a series. I'm seeing this now in the market of phasing. They're a fully insured small business. They're going to their health insurance broker saying, I can't afford this anymore. If I'm not going to drop, I want to keep it. They then strike a deal with a primary care doctor and they say to all their employees, you can go see them. I'll pay your monthly fee. They self-insure, so they look like a big business. They buy reinsurance. I know we're going way into the weeds, but there's like a phasing that's happening here in which small businesses are trying to align incentives where they're still taking care of their employees, but delivering care and changing the incentives. I think we're going to see more and more of that happening. We've started to see big businesses, whether it's Home Depot or Walmart, changing the way that they provide services to their employees. I think over the next 10 years, we're going to see that accelerate and hopefully some innovation emerge out of that as well.
All right. So, Dr. Smith, so different countries do things differently than the United States. We neighbor Canada, who regulates drug prices quite differently. A lot of European countries where their costs are lower. So is that an argument towards these types of cost controls?
Yeah, well, this is an infuriating issue to me, and it comes up in every forum that I speak to. And there is a genuine price differential between many wealthy developed countries and the U.S., and the U.S. pays more. That's conceded. But one should understand that biopharmaceutical products are uniquely susceptible to price freeloading in other countries. And the reason for that is the nature of the business model. Biopharma companies have high R&D costs and very low manufacturing costs. So let's choose another industry, a Michigan-based industry, Ford Motor Company, right? Ford Motor Company CEO gets a call from the Prime Minister of Great Britain saying, we want to buy 20,000 of your F-150 pickup trucks. The problem is we only have $15,000 in the budget per truck. So the CEO goes back to his team and says to the CFO, hey, they want to buy 20,000 trucks, but only $15,000. The CFO says, you're crazy. It costs us $25,000 to manufacture an F-150. We'll lose $10,000 on every truck. You've got to say no. Imagine the same call going into Pfizer. Pfizer, the prime minister calls and says, we're going to buy your new drug, but we're only going to pay 50 cents on the dollar. The Pfizer situation is very different than Ford because Pfizer has spent $2 billion, already spent money out the door on R&D, and it cost them less than 5 cents to manufacture the pill. So if they walk away from the deal with Great Britain, even if it's not a market price and it's not a fair price, if they walk away, they're walking away from 50 million in revenue. It's a very different situation than the Ford. And these companies are susceptible to having other countries freeload on price because they know the money's already been spent. We got to get a little revenue. We're trying to recoup our costs here. We can't walk away from the deal with Britain. So that's what's driving this. And in my view, the political establishment in Washington needs to make this a trade issue because biopharma products are largely an American industry. It used to be European, it's now American. And if we continue on this road with price controls, in a decade, the Chinese will be the leaders in life sciences research, in my view.
All right, we'll go last question. We'll go to Matt Mitchell. Why do you suppose California doesn't have con laws? And then a second part of that is this: what's the national trend on these laws over the last couple of decades? Increasing, decreasing, staying the same?
So the greatest time for laws in healthcare, right in the 1980s, when the federal government mandated right away. Well, states there's new laws. California was in that wave. A couple of these states actually looks legislation that said in the event federal inducement goes away. So I think there's a little bit of maybe safety in numbers at the time or something like that, or maybe it's a good illustration. Top choice to make that might take away special interest privilege. It's better to just do it right away rather than hope that it'll be easier later. So one thing though that has happened is after the certificate of need laws have gone away, typically hospital associations, even though they really oppose their elimination, they don't really excited to bring it back. So for example, you can talk to the Hospital Association in Pennsylvania that takes the position that they would rather their laws not come back. There's such a difficult thing to comply with that, as we tend to say, that there's typically only a transitional gain to anti-competitive behavior like this. Like you only get a little bit of a boost in the short run, the law is put in place, but in the long run, competition takes place on other margins, and the compliance costs are coming up that it's not even effective. Which again is against the belief by empirically that when states get rid of common laws, profits would dip, but then they often recover after a short period of time. Okay, so what's the trend? Maybe the second most important time for the elimination of common laws is right now. So during COVID, about 24 states relaxed their certificate of need laws, and I think a lot of people were shocked to find out that the state actually requires a provider to have to prove that they need to add another hospital bed. You know, people are dying right now. Shouldn't they just be able to add a hospital bed? Need a relaxation. And so I think that sort of spurred quite a bit of interest in reform. So generally, the move in the last few years has been for states to pare their common law back. Sometimes it's just nibbling at the edges. States, thankfully, are in recent years are getting rid of common laws for specifically stating the way to care for vulnerable populations, like those who are looking for substance treatment facilities, or those who need psychiatric care. So we're seeing a little bit of nibbling at the edges, and then more significant reforms, as I mentioned. Florida was a big one a few years ago that got rid of almost all their common laws, but Montana got rid of 8 common laws, leaving only 2, and then South Carolina just did away with almost all common laws but 1. So pretty significant reforms. I would anticipate that this is just going to continue. There seems to be a geographic element here that legislators and others are aware that, okay, if there's no common law in our neighboring state, or our patients having to leave the state in order to care, maybe we need to address that. It doesn't make it easy. There's still that concentrated benefits and diffuse cost problem, but the trend is sort of moving in a positive direction.
All right, thank you. Thank you very much for our panel. Thank you all for coming. Thank you for everyone streaming this online. You can find more about us at mackinac.org. Sign up for our mailing lists, learn about our news website, our legal services, all different policy areas across the board. And we hope those here in Lansing join us on November 8th. Our next issues and ideas topic will be on zoning reform across the state of Michigan. We have a really great panel on that, and thank you all for coming.